Great. Welcome. I'm Dr. Jonathan Sargent. I'm the Chief Medical Officer of Generated Health. We run the Florence platform, which is an intelligent messaging platform, which is deployed into the NHS to support clinical teams with efficiency and staying connected to their patients, and also supports patients to look after themselves. Today, I've got great pleasure of being joined by Sean Davies, who is the Directorate Manager of the Cardiology Department at University Hospital North Midlands. They've been using the Florence platform for a number of years, and we're going to explore with them how this has benefited their patients and their teams, and some of the intricacies of understanding how to keep things simple. Sean, welcome. Thanks very much. Tell me a little bit about introduce yourself, and tell me just a little bit about yourself and how you landed in this in this role at University Hospital North Midlands.
Thank you. Nice to be here, and thank you very much for interviewing me. So yeah, I joined the NHS about a decade ago. Before that, I was a business analyst in a number of different private companies. Joining the NHS, started as an analyst, and then got involved in quite a lot of projects, one of which was with the Smart With Your Heart project, which we use Florence to remotely monitor the health status of heart failure patients. The project was a great success for us. It had a lot of really great metrics associated with it. And since then, we've gone on to use those same kind of principles within a number of other projects. So we've been using it in TAVI patients, so patients who are awaiting a TAVI and those that have had a TAVI.
And a TAVI is, for those people who don't know, because I had to look it up.
It's a trans sub. No, that's a TOE. It's essentially a valve that you implant within the cath lab rather than having to have open heart surgery for a valve replacement.
Right, correct. Brilliant.
I apologise for not knowing the acronym off the top of my head. And then we've also implemented it within cardiac surgery. So for all cardiac surgery procedures, both in a pre-procedure and post-procedure status. And we are now, on the back of this project, are taking the learnings from both Smart With Your Heart and from the TAVI and cardiac surgery remote monitoring projects, and implementing them in an evolved Smart With Your Heart project as part of the Managing Heart Failure at Home programme, alongside the NHS England and NHSI.
Wow. So it's amazing. So it's really sort of grown from a small pilot to something that's now having a significant impact, and hopefully bigger impact in the future. And that, I mean, working with customers who manage to do that is, it's just come like a dream for us at Generated Health, so that people really see the benefit of it. I mean, I joined Generated Health a couple of years ago, and the reason I joined it is just because I saw it as such a simple thing to basically communicate with people through SMS text messaging, using some algorithms to structure the conversation and to enable us to put in, the key clinical components that you need in there, but also to give people a sense of being connected to their clinical team in between consultations or events or workup to particular interventions. So just with the Smart With Your Heart, obviously that's been evaluated, and it was done, I think, in sort of 2020-ish, wasn't it? And around, they took 100 patients, and they were able to, if I understand right, you had some pre-intervention and kind of uses of our protocols, and then some post-intervention of our protocol. Is that about right?
Yeah, absolutely. So we took data from our pre-intervention group, which was a patient cohort with relatively same comorbidity indexes, age profiles, age and sex, for example, and then we measured that against the outcomes from the project group of patients, and we compared the outcomes in a lot of different ways: length of stays, readmission rates, A&E access, costs to the health economy. Yes. And in almost every metric, there was an improvement between the pre-project group and the post-project group within the project. And it was a difficult project to get going initially, because it was kind of a bit of an innovation for heart failure. People were a bit reticent to take on this remote kind of care of patients. But now that the evaluation has been done and the results are plain to see, that there has been a very positive kind of reception around this project, and this is where we're moving forward with the Managing Heart Failure at Home project as an
Right.
evolution of that.
So just I understand that you did something quite I think quite quite innovative in terms of, instead of just collecting metrics through the text message communication, you asked the patient how you're feeling, didn't you? That was basically, I think, what you're doing. Was like, and they had to say whether they were sort of feeling, green, amber, or red, and then you had a bit of side information that every patient had that they could look at, that said, well, if you feel like this, look out for these types of things, and so they could get a sense of what direction are they tracking in. Is it?
Yeah.
And that was one of your consultants is a big advocate of that. Is that right?
Yeah, so one of the main drivers behind the project was Dr. Dargo Sachi. He's a very passionate man who's got a lot of very innovative ideas. He's normally a couple of years ahead of the trend, and in this instance, he looked at the documentation that we were already giving to patients that were saying these are the warning signs to look out for,
Yeah.
and when you look at the pre-project group, these people would identify these signs and then have to re-access the start of pathways or reintegrate with themselves with whatever part of the pathway they were on, and it just took time. And with the Smart with Your Heart project, essentially every other day asked the patient a very simple question. It wasn't around physiological monitoring or anything like that. It was asking, how are you feeling? Because we give quite a good education to heart failure patients around what signs to look out for.
Mm-hmm.
And I don't think there are a better judge of a patient's health than the patient themselves.
Yeah, right.
So their response saying, I am feeling better, worse, the same, or in response to a symptom checker, which is we adopted the pumping marvelous red, amber, green status. So red being I have deteriorating symptoms, amber being I have some symptoms, but actually they may be related to a different medical concern other than my heart failure, and green being actually I'm absolutely fine. We adopted that as the responses that we required. If a patient responded to say that they were red, amber, or worse, then we would have a telehealth coordinator, a telehealth worker to contact them and to track those symptoms and then report to the most appropriate pathway. And they acted as an advocate for the patient to make sure that they were getting to the right people, so that we didn't have, you didn't have to go to the GP in this instance. You might be able to skip that step and go straight to the heart failure nurse or the community. And yeah, it puts a lot of trust within the patient. But actually, what we were seeing was that the patients weren't abusing the service. They weren't, you know, tracking symptoms that were non-existent just to try and get an appointment or some things like that, which were initial concerns around doing it this way. But actually, patients were telling us what we needed to know, and we were acting upon that information.
That's amazing, isn't it? Because it's a really good point. It's like I definitely hear from clinicians, oh, if we increase our communication channels between our patients, people are just going to use it a lot and they're going to be there. But actually, I've always found people are incredibly respectful of having these types of tools and use them predominantly in a very useful way. And one of the things I thought was the beauty of what you did with the Florence protocols was you kept them super simple. And you also, how long did you maintain communication with the patient? Was it over like 3-6 months through the Florence platform?
Yeah, so for once they were onboarded onto the project, it was for 3 months. The first 2 months, the text messages were once every other day. And then the last month it started to tail off a little bit. It got down to once every 4 days before they got towards the end and had an evaluation. So yeah, it was quite intensive up front. But actually what like you say, people were expecting this to generate quite a lot of additional contacts with clinicians.
Yeah.
But what we saw was that actually patients were quite respectful of the fact that they did follow the documentation that we provided and the education that we've given them on how to use this, and that they were using it in an appropriate manner, so that we could stratify those patients that did need to be seen by a clinician, and those that needed to be seen urgently, and get them to the right people at the right time.
And what was the sort of feedback from patients? Were they in terms of using the tool, the simplicity of it, or?
Yeah, I think the great thing about using Florence in this instance is the fact that text messages are a technology that almost every age cohort of patient will be familiar with. Other technologies that we've looked into use apps and things that the heart failure demographic is traditionally older, and they are less trusting of apps, and they are less trusting of websites and emails and things like that, which text messages is the technology that they've had around for a while, and that they are comfortable using. So yeah, from an accessibility point of view, patients were very happy with the kind of process and the technology in which they were using. It was something that was familiar to them, and the outcomes at the end, the assessments were very positive from patients. They had a very good experience, and that they didn't feel that they were being not seen because of the remote monitoring, but that they saw that they could access pathways when they needed them.
Yeah, which is great. And critically, I understand that both of the attendances into A&E and emergency readmissions for deteriorating patients were significantly reduced. And
Yeah, Dr. Satch's got the exact figures, but if and I believe it was less than half attendance into A&E for
yeah, yeah,
the project group.
I read the thing. I read the evaluation this morning, and it was saying that you had a 44% risk reduction of attendance in A&E and a 67% risk reduction in emergency readmission, which is, I mean, this type of critically, easily deteriorating patient is such a fantastic kind of impact for such a simple thing, isn't it?
Absolutely.
which is
Yeah.
which was fantastic, and I think that was turned into some numbers in terms of money. And obviously, emergency admissions cost about £3,000 a day or something in that vicinity. And I think it was saying that it was, in this project, could have released savings around £344,000, which is pretty significant. You had an individual looking at, because we've got a platform where you can see all the patients who you're running protocols with. So you put one person in place. Was that an administrator or was it a clinical person?
We had a telehealth coordinator, so it was a
Okay.
non-clinical person. So we had, I think it was two telehealth coordinators that were non-clinical members that managing that on a part-time basis. So it was kind of one whole-time equivalent that was managing the communications for the hundreds of patients that we'd onboarded.
Wow. So I mean that's a fantastic pilot, and you then went on to the next step. So tell me a little bit about TAVI and people for cardiac stents and the scale of that you were working at.
Yeah, so we looked at, obviously, the outcomes from the Smart with Your Heart project was impressive, and we were looking at other places. Sorry, somebody's in my door. We looked we looked at the outcomes, and obviously in a post-COVID world, we were looking at ways that we could recover our waiting lists, and obviously we through TAVI and cardiac surgery, these patients are high-risk patients, and they were waiting longer than we would have liked. The idea behind applying the Florence, a very similar protocol to the TAVI and cardiac surgery patients, was that we can risk stratify those patients that are on our waiting list and have deteriorating symptoms, and then to bring them in earlier if they are clinically urgent and they require
Yep.
that intervention, which means they don't have to go through A&E, they don't have to go through sitting on a ward waiting for it to be scheduled. They were highlighted to the surgeon. So the pathway was that every other day we would text the patient to say, "Are you red, amber, green?" And in this instance, we created our own symptom checker, which was very simple to the way that the Pumping Marvelous Red, Amber, Green is set up, but it's more related to valve symptoms and the reasons why you would want cardiac surgery. We then asked, on alternate days, are you better, worse, the same than we last spoke? And obviously, if a patient flagged red, amber, or worse, they would get a call from a telehealth coordinator who would collate those symptoms and
Yep.
then highlight that to the surgeon, who would then take that to their scheduling to ensure that that patient was being seen either within a clinic or to be booked in for surgery as soon as physically possible. For TAVI, it works in very the same way. We would take this to our TAVI, a dedicated TAVI nurse, who would then call the patient, bring them into a clinic, or book them into a TAVI procedure as soon as possible. It just meant that those patients that, those clinically urgent patients who'd hadn't waited a particularly long time on the waiting list, may have got progressively worse during their time on the waiting list, and they were waiting longer than we would have intended, could be brought in and done clinically urgent.
That's amazing. So how many people are on your waiting list for that type of those types of procedures at that
Now,
time?
At the time, there were several hundred people waiting for a combined cardiac surgery or TAVI.
Yeah.
We kind of combined the pathways to look at valve interventions. Now we are less than 100.
Wow.
So using this system, we've been able to bring in the patients that are clinically urgent, and then manage to reassess those patients that haven't been clinically urgent to make sure that they are ready for any availability in theatre capacities.
That's fantastic. And in terms of onboarding people to using the protocols, what did you find was most effective?
So when we first started to do this, we were attending consultant clinics so that we could be there at the time. What we found was within those first weeks, we learned a very valuable lesson around the fact that if a patient is told that they're going to have a procedure, sometimes that kind of shock sets in where they weren't particularly interested in what a non-clinician was about to say to them after they've just been told you're going to have heart surgery.
Yes. Yeah.
So what we did was we adapted that approach to give the patient a call on the phone once they had I think it was a day post being listed,
Okay.
and then we sent them out a letter which contained all the documentation, a consent letter, a quality of life questionnaire so we could baseline them, and once they'd agreed to join the project, we would sign them up over the phone. They would get their text message through Florence, and we would proceed from there on the protocol. Um, we have so few refusals to come onto the project
Right.
now. Very few people decline the want to come onto the protocol. I think that's primarily because we've learned a lot of lessons, and the way we've onboarded patients evolved very early on, noticing that they're actually approaching patients within a clinic perhaps wasn't the best in a kind of situation for the patient. Um, it probably would have been best if the clinician themselves had done that onboarding process. But the idea of the project was to try to impact the clinical team as little as physically possible to get as much buy-in from them as possible. If you had clinicians that were truly really engaged in this process and wanted to do this, having that conversation to say, hey, you're going to have cardiac surgery, we have this service. It's a safety net for you in the preoperative period. We'll be able to bring you in should you deteriorate, and in the post-operative period for the 3 months, we'll safety net you to ensure that any deteriorating symptoms or any infections, etc., will get you seen by a clinician quickly. If that was there, that would have been ideal. But I think we did a really great workaround, which means that, like I say, the team are excellent in the way they've adapted to those things.
And I mean, I think, yeah, really, really great that you found an effective way to get people on board easily. And I do think when people receive bad news, that having a heart op is pretty scary news to be told. Your brain just goes into a mess anyway. So probably, um, you put in the best solution. And I'm sort of really pleased to hear you had a very high uptake. We've been doing some work in America, particularly around GI operative interventions, and we have like a huge, an amazing uptake and completion of the protocols, of like 97% or something, because people are fully engaged in, oh, this is actually going to be useful to me, and it's going to help me prepare, and I'm going to get a little bit of looked after afterwards. And also I'm a GP by background, so I didn't explain one of the things that my bugbears is, trying to phone up the hospital when there's things that have gone wrong and getting people back in. But it's fantastic to have like an ongoing support in that way. So that's super good. And what kind of scale did you get to with that project?
So it started slowly, but eventually within um, a few months of starting the project, we'd onboarded all of our TAVI and cardiac surgery patients. There was 900 instances of patients on the protocol,
Right.
very few dropouts during that period, and very few patients that ceased to communicate with the protocol. We're talking handfuls of patients over that 900 that did want to continue with the protocol. I think I think most patients saw it for what it was, as a brilliant tool to look after them during this period. And yeah, it was pretty successful for us.
Yeah, fantastic. I mean, you used it for a solution that I've been wanting people to use Florence for, which is like managing that backlog in care and just staying connected with people, so that you can pick out the people who really do need things quickly. Um, So that's two really great use cases. And in terms of the heart failure at home, what's the ambition?
So what we want to do with managing heart failure at home is to kind of learn the lessons that we've had from the TAVI and cardiac surgery project, as well as the Smart with Your Heart, to couple remote monitoring via the Florence system with an online library of content that patients can access at any time, alongside a patient educator. So the idea being that we see within heart failure, when we do these projects, that education, etc., is obviously increased as they are engaged. But once you're out of the careful, watchful eyes of the heart failure nurses within the hospital, with the community, that education starts to slip. The idea is that to use remote monitoring to engage in a safety netting style activity for these patients in their most vulnerable times, as well as using a patient educator who can speak to them remotely to ask around any questions they have around pathways, and to deliver an education which is on par with what we're already delivering now within our cardiac rehab and cardiac nursing bodies. The idea is that essentially the very same aim as previous projects, safety netting patients, stratifying their risk, utilizing remote care to avoid face-to-face contacts if necessary. Because for some patients, coming into hospital can be just as risky as staying at home, sending a text
Yeah.
message. So yeah, it's a very promising project, and we put a lot of work into it, and it's hopefully going to be going live within the next week or so.
And so have you been involved in building the protocols at all, or is it parts of your team? How have you found that sort of process of, getting the protocol kind of designed and built?
I would say that the process to building the protocols is very simple. The folk at Generated Health and within Florence, they have been incredibly helpful at guiding us at what works, and that when we give them an idea, they've provided like a flow diagram, which makes it very easy for the clinicians who've really not interested in the nitty gritty. They just want to see if it works or not, for them to understand how that would flow. Um, Actually mapping that out to our pathways was the more of a challenge than actually getting it working in Florence. Um, and it's been a very, very simple and simplistic process for us to build those protocols within Florence.
So one of the other things I'm curious about is obviously on the platform, which John, who's in the webinar, might be able to show you briefly as an audience, is you can see the patients who are engaged in the different protocols, and you can see the patients who stop engaging. Have you had any sort of feedback around how you've been able to like re-engage people who've kind of stopped communicating, because you might worry about them?
Yeah, so what we've been doing is monitoring those patients that have stopped engaging, and what we've looked at is we give them a phone call if they stop. So one of the telehealth coordinators will give them a call just to see if everything's okay. For some of these patients, they come from quite a wide geographical area. Some of them have been in hospital, and what we've done is pause the protocol, and so that we give them a call when they get back out of the hospital, so we can commence the protocol. Some patients are on holiday, and they don't want, they're having a good time, and they don't want to reply during this period. So we say we won't stop sending you the text messages just in case you need us. But we know that you're on holiday now. You've been away for 2 weeks. That's fine. Okay, we understand that. Um, in general, it's not been difficult to manage the patients that haven't replied on a regular basis. We have seen some patients just respond when they want us, and because you kind of get accustomed to the patients that are within this group, and some patients will, they'll reply once a week, and that just keeps them off our radar to say, okay, that's fine. But those patients, when they do want to flag, will flag. For most, I think the last time we tracked this, we had 60% of patients had never flagged as red, amber, or worse. But for those 40% of patients that had flagged once, they've had an appropriate response,
Okay.
and it's been valuable to be able to track that kind of data to say how patients are using this and the lessons that we might use moving forward.
Okay, amazing. And what's the kind of, how many heart failure patients do you kind of going to be that heart failure at home, what's that could be huge, couldn't it?
It could. The initial target is 100. So we've got funding until the end of March, and then
Yep.
once we're beyond that, I think it begins to pay for itself. So,
Yep.
if we get, obviously the lessons from Smart with Your Heart indicate that there's a saving for the health economy. I think it was, I can't remember off the top of my head. You'll probably know better than I will, but I think it was £1.50 saved for every pound invested.
Something like that.
So obviously it's an investor save scheme, and
Yep.
by March, I'm fully expecting to have our business case through and for it to continue on for as long as physically possible. And obviously, hopefully evolving based on patient feedback, because this is one of the increased things. We've increased the number of questionnaires and things we want to ask patients around what works for them and what doesn't. But based on everything we've done so far, we've kind of hit a very sweet spot around using the technology that's simplistic, that patients feel cared for. But we'll see what lessons we can learn moving forward and implement them as we go.
That's fantastic. And just a curiosity, do you talk about this outside of the cardiology department? Did people sort of understand what you're doing there and how
Yeah,
they can use this technology?
we've had visitors from other specialities within UH&M. We've had kind of other trusts come and have a look at what we're doing. I know that there are pushes from other trusts, and I think other trusts are kind of limited to what kind of tools they can use because of their ICBs have signed up to particular ones. And so within our kind of trust and our ICB, there has been interest in expanding this, and I know that cardiac rehab have used it, and that I think pre-assessment we're keen on using it. I think for us, we're really concentrating on making sure that we get our things right and that there is success. But we are more than willing to share whatever lessons learned with anyone who wants to come and listen. And Dr. Sachi will speak very passionately about to anyone who wants to listen around these projects.
That's great. Oh, Sean, look, thank you so much for explaining it, and thank you so much for being, really putting the time and energy into using this platform in the way to get the effects that you have really on patients and also on your clinical teams. So it's been really useful to listen to you talking about it and giving us a real sense of it. So, look, thank you very much indeed. And what we're going to do is we're going to hand back over to John Griffiths at Generated Health. Thank you.
Thank you very much.
Oh, cheers.